I welcome Professor Ramsamy sir for a very interesting session. A 3-year-old child with PhD coming for anatomical correction in a cardiothoracic theatre. Dr. Mubin will be presenting the case, sir. Over to Dr. Mubin. Shall we start the class, sir?
Yeah, please go ahead.
Yeah. Good evening, everyone.
Thank you, sir.
Good evening, everyone. I will present a case about Master Adesh Maurya, a 3-year-old male child coming from Paltanpur from Uttar Pradesh. The informant of the history is by the father, Mr. Danish Maurya, who is working as an electrical engineer in Gorakhpur Railways. Coming to the chief complaints, the chief complaints are there is a poor and difficulty in feeding since 1 month of age and poor weight gain since birth. Coming to with this complaint, the patients came to pediatric OPD. Coming to history of presenting illness, the child has features of very difficult, poor feeding habits since 1 month of age. The child starts feeding, and in between the child goes into rest and will not feed, and again after some time the child starts to cry and requires feeding. This has been done during the breastfeeding period, and which continues till now. The child has poor appetite and has stopped taking solid foods and has very long duration of feeding period. Coming to history of poor weight gain, since birth, the child has been given to when shown to different pediatricians in view of poor weight gain. There is no history of any fever at present. There is no history of any edema. There is no history of cyanosis. There is no history of squatting. There is no history of seizure disorder. There is no history of focal neurological deficit. There is no history of shortness of breath. There is no history of any forehead sweating. With this complaint, the child presented to the pediatric OPD.
What was the age of the child when the child is brought to the hospital?
For this episode, it is 3-year-old child.
Right. But the symptoms were noticed right from the first month after birth.
Yes, by the month.
So all the 2 years, I mean, till this up to 3 years, they have been waiting without doing anything for the child.
They have been showing to multiple pediatricians all over the various places.
Okay.
And yet now again they have come to the pediatric OPD. From there, with these complaints, they have examined the patient and they have referred the patient for cardiology assessment reference. From that, the patient has been referred to cardiothoracic surgeon.
Okay. Any diagnosis made after seeing multiple pediatricians?
Yes, sir. Diagnoses have been made.
As a case of VSD or what other?
They have diagnosed as congenital heart disease, probably ventricular septal defect. When here it was diagnosed as patient not in features suggestive of cardiac failure. Congestive
failure. Okay, congestive cardiac failure. Okay. Right.
So
supposing a child is born with severe congestive cardiac failure, is it possible to make a diagnosis of that congenital heart disease, whatever it may be, by just a physical appearance examination of the baby?
With just congestive heart failure, sir?
No, any congestive, congenital heart disease. I'm not saying congestive heart failure or cardiac shunt or valvular defect, whatever it is. If any child is born with congenital heart disease and it is a very severe degree, as soon as the baby is born, if there is no pediatrician or a neonatologist available and you are the anesthetist who has given anesthesia to the mother. Let us say it is a cesarean section and you are given anesthesia. You are given a spinal, so you are free. And physician, after delivering the baby, hands over the baby to you to say, sir, today pediatrician is not available, neonatologist is not available. Can you just take care of the baby? By examining the baby just by inspection, not palpating or not auscultating, is it possible to diagnose
Yes, sir.
a severe congenital heart disease? What are
Yes.
the features that will be presenting for inspection? I'm not telling about auscultation or examination
There
and
can
all that.
be visible apical impulse.
Visible apical impulse. Okay. More
General
than that,
examination.
yeah,
Say the
just the
general
inspection. No,
examination.
no, just a simple inspection. Can you
Mm.
detect something is wrong with the baby?
Cyanosis can be
Cyanosis, very good. It can be bluish or cyanosed, very good. Okay. Anything else?
uh, very difficult, but can raise the
Huh?
respiratory distress.
Tachypnea. Don't call it respiratory distress, but tachypnea. If the child is breathing hurriedly as soon as it is born, okay, normally itself there will have a little bit of number of respirations will be more in a newborn compared to older child. But if it is very tachypneic and if it is little cyanosed, then it's an obvious thing that something is wrong with the heart or maybe a congenital heart disease. Then when you palpate, I mean, if you are allowed to examine the child further from inspection to palpation and auscultation, what are all the features you can pick up?
As mentioned earlier, apical impulses will be.
Apical impulse, okay. So all cases, apical impulse will become very prominent.
No, sir. But
What will be the heart rate if supposing there is
tachycardia.
tachycardia more than 200 may be the rate, okay? Then can you pick up some murmur?
Yes, sir. Murmurs can be.
So these are the 4 things that you have to look for. By inspection, you can look for tachypnea, cyanosis. By palpation, you can find out for tachycardia, and by auscultation, you can pick up a murmur. Okay, so these are all the methods by which, as soon as the baby is born, as an anesthesiologist, you yourself can pick up. But if there is a neonatologist or a pediatrician available, they should be well trained in picking up these problems. Okay, so you must have asked a history whether any such feature was present when the baby was born. Because within 1 month of birth, it has stopped taking feeds, it is not thriving well. So some hint must have been there at the time of birth itself. Usually, an intracardiac shunt from left to right does not cause problem. Will it be very obvious even at the birth?
No, sir.
No. What is the age at which it starts manifesting and why it is so late?
Sir, at least it will take 4 to 6 weeks.
Why?
The rise in pulmonary vascular resistance will come down to normal adult level by 4 to 6 weeks, wherein the shunt will operate well.
So
usually the first 1 month or 1.5 months, the child will not have exhibit much of the symptoms of shunt.
What exactly happens? Why these first 4 to 6 months you don't have symptoms?
The pressure on the right side is more than
so what will happen? The pulmonary vascular pressure is slightly higher than compared to an older child. So
the flow will be hindered from it will not be patent enough to go through the septum.
So how to exactly scientifically describe that? What ratio you have to describe?
Pulmonary vascular system.
What is QS-QP ratio?
Flow over the pulmonary side to flow over the systemic.
Systemic and pulmonary is flow. Okay, QS-QP ratio is very, very important. So in the initial phases, because of the slightly increased pulmonary vascular resistance still persisting even after birth, the left to right shunt is very, very minimal or moderate. Okay, Whereas once when the pulmonary vascular resistance reduces and becomes like a normal person, normal adult, then what happens? The left to right shunt increases. When the left to right shunt increases, what will happen to the volume on the right side? There will be more congestion, more volume, more work on the right heart. Okay, that is the time the child starts exhibiting all the features. Okay, so that is the reason why this pathophysiology you must understand clearly so that we can pick up, because many a time you will say even the pediatricians would have certified the child as normal except for a mild murmur which may be functional. How come a doctor can mistake a murmur present as normal? What are the other murmurs which may mimic as though there is a VSD or ASD? Where is the other communication?
PD.
Extracardiac communication is there, isn't it? Even a PDA can, even though it is supposed to be a continuous murmur, only when the flow is very high, it will be a continuous murmur. Otherwise, it may mimic an ejection systolic murmur, just like what you have during the VSD or ASD. That is the reason they may mistake it. Or even if it is present, they may say it is because of the lack of closure of the developmental openings that are there in the heart, and it flows automatically. So that may be also presumed like that until the child becomes very symptomatic. Okay, right. Okay, go ahead. Is it born of consanguineous marriage, the baby? Have you come to that history
Yes,
part?
sir, it's a non-consanguineous marriage, sir, and it's a first child, and so far it's the only child.
If it is a congenital anomaly, what are all the chromosomes that are involved?
Usually it would be trisomy 21, trisomy 13, and trisomy
13, 18, 21. Okay, 13, 18, and
18,
21. What do you mean by trisomy?
The particular number of chromosomes will be in the triplets.
Instead of 4, it will be 3. Very good. Right. Okay, go ahead.
Coming to past history, the father gives the history of previous hospitalization for fever, cough with sputum at the age of 8 months and at the age of 2 years, and also 2 months back, for which the child was given intravenous antibiotics and supplemental oxygen therapy via face mask. The fever subsided with the medications, and it is not associated with rash or seizure. And there is no any previous history of surgeries. Coming to medication history, the patient is currently on oral syrup given one time a day, and nebulizations whenever the child is being complaining or having tachypnea. And the father says that currently the syrup is given for increase in urine output. The drug, name of the drug, that father doesn't remember. And the patient is currently on this medication, sir. And coming to the antenatal history, the mother, the child is the only child born out of non-consanguineous marriage. And during the antenatal period, the mother was booked in ANC clinic and had regular visits. There was no history of fever with rash or any lymphadenopathy during the antenatal visits. There is no history of any torch infections. There is no history of any drug intake or alcohol intake or smoking. And there is no history of diabetes or hypertension during the pregnancy. And also there was no history of any X-ray exposure.
Very good.
Coming to birth history, the child was born by as a full-term normal vaginal delivery, and the baby cried at birth, and was there was a history of admission to intensive care unit for the babies, but the reason for which the mother or the father doesn't remember, and the baby was in the intensive care unit for 3 days before returning back to the mother, and the birth weight of the baby is 3 kg, and there was no history of any prolonged jaundice or petechiae or seizure in the newborn periods. Coming to developmental history, the child attained milestones up to age. And immunization history, the child was immunized up to age. Coming to dietary history, the child was exclusively breastfed for the first 6 months and started on solid foods from the age of 7 months and currently on solid foods. But the mother complains of poor appetite. There was no disturbances in the bowel and bladder habits. This.
So these are all the history. Okay, it's a fairly detailed history that you have taken. So now the medical management, some syrup to cause increased urination.
Yes.
Did you ask about any history of sudden palpitation-like features where the child went in for some seizure-like activity with the rolling up of eyes on the transient loss of consciousness, anything like that happen?
As per seizure history, sir, the father didn't give any such histories.
No. Did you ask and get any negative history like that? Did you ask for any transient rolling up of the eyes and child becoming staring for a few days, not responding for a few seconds and then retaining? What is the importance of that history? See, we cannot ask like an adult. This is a baby. So we are reliant only on the informant like father or mother for the entire information. Okay. So can a child with a congenital heart disease develop a what is called minor seizure like petit mal like features? And if it is so, what is the importance of that? What one aberrant conduction it can happen? Is there any possibility of arrhythmias in the patients with congenital heart disease?
The possibility of arrhythmias are there, sir. But
what sort of arrhythmias they can have?
Supraventricular.
SVT is very common. Atrial fibrillation is also very common. So if that is there, can they have microthrombi getting distributed? So it will not be a frank infarction in the brain, but it may be a microthrombi causing this sort of transient petit mal like features. Okay, so that question you should always ask that is present. That is, what does it warrant? What should you take care of?
That means there is chance of air embolism during surgery.
Air embolism is now what we create iatrogenically. This is something which is happening inherently in the child. When will a thrombus form?
During stasis.
Stasis. So the stasis. So how do you prevent that thrombus formation? What other medication, antiplatelet agents should be required? Okay, so that also is an important history that you should ask for. Unless you ask, they won't be able to tell you, because they would have seen that once or twice and forgotten about it. So unless you probe them, you will not get that history. Okay, right. Okay. So you have asked for all these things. Now go ahead with the examination and complete your presentation.
Coming to general examination, the child was conscious, sitting in the father's lap. He was alert and was malnourished. There was no signs of pallor, icterus, cyanosis, clubbing, or lymphadenopathy. There was no facial or skeletal dysmorphic features. Coming to vital signs, the pulse rate was 130 per minute. It was regular, normal in volume and character. There was no radioradial or radiofemoral delay. There was no apex pulse deficits. Coming to the respiratory rate was 22 per minute. The child was afebrile. The BP was 112 by 60 mm of Sg. The room air saturation was 98%. Coming to anthropometry, the child weighed 12.4 kg and the height was 90 centimeters and the mid-arm circumference was 11 centimeters. The weight was marked between 3rd and 5th percentile. The height falls under 15th and 50th percentile, and the mid-arm circumference was in the red zone. Coming to cardiovascular system systemic examination. Coming to cardiovascular system examination, first inspection, there was no scars, sinuses, or dilated veins seen over the chest. Apex impulse was seen. There was no chest wall deformities. Coming to palpation, the apical impulse was felt at the 5th intercostal space. lateral to the mid-clavicular line.
Mm.
That was a hyperdynamic case. And there was a left parasternal thrill present and a palpable P2 was seen, sir. Coming to auscultation, the first heart sound was normal, but the second heart sound was having a split, a wide variable split, sir. And the P2 was loud. There was no other, there was my two added ones, sir. One was ejectance systolic murmur, which was seen in the apex and in the left to lower sternal border, and also ejection and diastolic murmur present in the apex. Present in the apex. This is a cardiovascular system examination. Coming to respiratory system examination, the child was having 22 breaths per minute. There was no intercostal retractions or nasal flaring. On auscultation, bilateral air entry was equal. There was no Krebs or any added sums. Coming to the system, other system examination, abdominal system, there was no organomegaly on palpation, and there was no abdominal distensions. And coming to central nervous system examination, there was no signs of any, there's no features of focal neurological deficits, as well as all the muscle powers and movements of the power of the upper and lower limbs are equal normal. Coming to airway examination, mouth opening and neck movements were adequate. Malampati grade was 1. There was no retronactia or any facial deformity or feature suggestive of any anomalies. Spine was normal, sir. Then the teeth, there was a loose teeth in the left side incisor. This.
Okay. So your examination is complete. So with regard to murmur, you said two different murmurs. One near the sternal border and another the apex.
Yes,
Is it?
Yes, sir.
So you could distinguish between the two, or both of them were of the same quality and the harshness, the timing, everything was same or slightly different?
Slightly different.
Why there are two murmurs? How can you make out two murmurs in the same child? What could be the reason? Normally we go by the parasternal area for a hollow systolic murmur. That is the classical description. But if you are able to hear another murmur at the apex also, which is different or slightly different in character from what you hear at the parasternal area, how will you account for that?
Can be associated with.
What murmur can we get in the apical area, sir?
That's what I'm asking. He has mentioned two murmurs in this description of examination, one near the parasternal and another at the apex. That is what is the description. But he can justify that. It may be present. If it is a multiple VSTs, it need not be always a single hole. Okay? It can be multiple. What is Swiss cheese VST? Have you heard of that condition?
Sir, in muscular VST.
There can be multiple holes. Okay, so there can be a transmitted or a separate murmur-like thing which can be elicited at the apex also. So that is a condition. You can say that even if you have made out correctly those findings, and you can always explain how it can happen by this particular answer. Okay, so it need not be always a single hole. It can be multiple also. So then in that case, you will get this sort of different locations of the same quality murmur also. Okay, right. That is one point that we have to clear. And another, you said there are no congenital anomalies, associated anomalies. What are the common question you can be asked is, what are all the other syndromes or anomalies which can be associated with this congenital cardiac defect? What is the acronym that is used for two very Vactral anomaly and charge anomaly? Very good. So you must be able to explain each one of the component of the Vactral and charge. Okay, right. So these are it's a fairly good examination that you have done that. Okay. Now what is the treatment this child should be offered? The main complaint that has been brought is it is not feeding well. Okay, and not thriving as a normal child. So how are you going to proceed?
Sir, first the child has to be
Before that, you have not concluded or made a
diagnosis.
summary and diagnosis. Okay,
Summary,
you have completed all your clinical examination. So, final conclusion has to be given. What is your diagnosis?
Summary: 3-year-old male child coming with the complaints of poor feeding and poor weight gain since 1 year of age, with the recurrent history of lower respiratory tract infections and having features with the features suggestive of ventricular septal defect and not currently in congestive cardiac failure.
Okay, and in sinus rhythm.
And in sinus rhythm.
And one more thing, born out of non-consanguineous marriage. That also has to be included when you start the birth of the child. Okay, right. So your clinical diagnosis is established. Now, how are you going to, how to proceed with this child? It has been referred all the way from north for specialized treatment here. So how are you going to proceed? What should you do first?
So first we have to evaluate the size of the, we have to evaluate the defects.
Investigate the child. That is the first answer. Okay. So what are all the investigations you want to do?
Various, first non-invasive investigation like chest X-ray can be done, sir. To rule out any pulmonary edema or look for any cardiomegaly. Then
just because this class is on congenital heart disease VSD, you don't have to change your pattern. You can always go by the routine way of your the routine investigations, specialized
like,
investigations like that. Okay.
Routine investigations like hematological investigations.
Okay.
Like
in hematology, what do you want to see?
We want to see hemoglobin, sir.
Hemoglobin. Okay. Supposing the hemoglobin is very low, what will you infer? If the hemoglobin is very high, 17 grams, what will you infer?
Sir, if it is very low, it means the patient might be having iron deficiency or nutritional anemia.
Nutritional anemia, because the history itself saying that the child is not eating well. Okay. So if the hemoglobin is low, there is a justification to say it is poorly nourished. Very good. If it is on the contrary, in spite of poor nourishment, if the hemoglobin is 14 or 15.
Child is having hypoxia due to which.
Excellent. So there may be a reversal, mild reversal of shunt, which is not clinically made out. So there may be a hypoxia to compensate for that. The child might have developed a polycythemia. Good, very good. Then
I will look for electrolytes levels.
Why electrolytes you want?
Because the child is on some drug that.
Yes, the father says they are given some syrup to cause more urination. Probably I presume that it is a diuretic. So I would like to check the electrolyte. Very good. Okay, then.
That can be thrombocytopenia or
Platelets, platelet count, bleeding time, clotting time, all the profile, because in case the child needs any surgery, I would like to keep myself prepared with all the values so that I may know what to order for before I take up the child for surgery in case it needs a surgery. Okay, very good. Right then.
Then, no, as usual.
So you have done all the blood investigations. What is the next one?
Next, ECG and chest X-ray.
ECG, X-ray chest. Okay. What do you expect in ECG in a child where you have made a clinical diagnosis of VSD?
It can be signs, features suggestive of either.
Supposing in these 3 years the child has become very bad with the VSD, the condition has worsened very, very much. What all the changes you can expect in the ECG?
There can be features suggestive of both the LA and LV dilated features with tall P waves, dented P waves, as well as features suggestive of left ventricular hypertrophy. Heart can be even right and bi.
So how will you explain LVH occurring first and then RVH occurring later?
Sir, the flow from the left ventricular will directly, due to that high pressure, will directly enter into the pulmonary artery rather than going into the right ventricle. So the right ventricle will develop a strain only after pulmonary pressure rises. So initially the left ventricle will work hard. So it is the first one to die.
Is it because of the hard working of the left ventricle or some other reason?
What?
Is it a pressure work or it's a
Or
volume?
volume overload, sir.
So in order to compensate for the flow going to the pulmonary circulation as well as coming into the aorta, there is always a volume overload on the left ventricle, which turns on to pressure overload over a period of time, causing first left ventricular changes. Then gradually the pulmonary circulation starts resisting or not able to hold the excess flow that is coming. So the QP also becomes more. That produces strain on the right ventricle. So ultimately it will be a biventricular hypertrophy. So if it is early stages, you will have only features of LVH. But if it is a late stage, you will have LVH features with RVH features also. Okay. So which leads in the ECG, you will look for LVH features. Which leads in the ECG, you will look for RVH features.
For RVH, we can look for V1 and V2, sir.
V2, very good.
And for LVH,
even V2, what do you look for exactly?
sir,
Which complex will increase? P, Q, R, S, T, out of which one has to become taller or smaller?
sir, R wave.
R wave will become smaller. Okay. And so, of course, all of us know how to diagnose LVH. Okay. Using the formula. What formula? Sokolow's formula to combine the V1 and V6 or V5, R wave in V1 and the S wave in V5, more than 35 small squares is supposed to diagnose LVH. Okay, right, very good. So ECG will be there. X-ray chest, what do you expect?
Sir, if the style is having failure, there will be pulmonary edema features. Due to volume overload, there can be cardiomegaly features.
So pulmonary congestion or pulmonary hyperemia will be there, and if there is a biventricular enlargement, there can be a cardiomegaly feature also will be there. Very good. Okay. Then what is the next investigation you want?
Then I would like to go for transthoracic echo 2D.
Echocardiogram. Okay. You want to see what are the informations you would like to see in the echo?
First, what is the size of the lesion?
Very good. Size of the lesion. Then?
Height of the lesion.
Height and size. Very good. Then?
Then the wall thickness of the wall ventricle.
Can you see the shunt fraction or the flow that is occurring from left to right or right? Then can you assess the pulmonary pressures in echo by the size of the pulmonary vessels and the volume that is flowing? So all these features they normally report, pulmonary say pressures, pulmonary vessel diameter, right ventricular ejection fraction, right ventricular performance. Okay, everything will be given. So you have to look for all those things to assess the severity of the nature and the direction of the flow of the thing. Right. Then any other investigation required?
If you want to measure flow across the pulmonary and systolic, sometimes
supposing at the time of examination the child is febrile, would you be worried about something?
Infective.
Excellent. Infective endocarditis. So how do you find out infective endocarditis?
In a 2D echo, there can be vegetations that can grow.
Very good. Then?
And blood sample
culture. So you have to do a blood culture to find out whether there is any active endocarditis is going on. Okay, very good. Right. So if all these investigations are completed and already the patient has been put on some medical management, any other medical therapy apart from diuretics can be tried before you go for an interventional procedure?
Sometimes digoxin can be started.
Digoxin is not an ideal drug.
Only antihypertensive, one
AC
antihypertensive which can
inhibitors.
be.
AC inhibitors, very good. So AC inhibitors can be tried to remodel the
Right.
ventricles. Okay, so cardiac remodeling can be tried by giving AC inhibitors as a part of the treatment. Right. So if all these things have not worked, then what is the definitive treatment?
You can go for surgical correction of the defects.
Straight away surgical correction or much more simpler, less invasive?
Uh, trans arterial with coronary. I mean,
Coronary closure device,
closure device.
transcatheter closure device that can be first attempted. So what are the indications for attempting this arterial catheter closure device?
Usually defects that are smaller, like
Small,
moderate to
single, okay,
muscular.
muscular septal defects. Okay, these are the only things which can be closed easily, not the perimembranous or outlet or other areas which have all require only surgical correction. So echo will tell you exactly where the lesion is, and based on that, first you can try for a transarterial catheter closure. Then if it is not possible, then you have to go only for a open surgery. So what is the open surgery that you will do? Is it beating heart or non-beating heart? That is
It's a non-beating
off pump or on pump?
on pumps.
It's always on pump. So you require a cardiopulmonary bypass with a open heart surgery. Okay. What are the challenges in a pediatric case where you have to do a open heart surgery? I was told that this case was operated in your hospital 3-4 months ago. So
Yes, sir.
were you there? You
No,
did
sir.
the case?
No, sir. I was
So
not
you,
in.
you escaped. You didn't do that case. Okay. Right. Okay. Have you finished your cardiac posting? Have you
Yes.
seen any other VSD being operated?
Yes, sir. Yes.
Yes. Okay. Then it should be easy for you to tell all the management. Okay.
Coming to direct management, sir. How to?
So this child, let us presume that it is not amenable to transarterial catheter closure. Okay, so it has to be done as an open procedure with a sternotomy and cardiopulmonary bypass as an open heart procedure. Okay. Now this 3-year-old child, 12 kg weight, posted for open closure. Tell me all the steps in the management.
After completing pre-anesthetic evaluation and planned for surgery, I will go for pre-medication.
Any pre-operative preparations have to be done?
Pre-operatively,
any further blood investigations and preparations?
blood grouping, typing, and
you have not said about that. We have said only about the CBC, the platelet, and bleeding time, clotting time. So it is very, very important in all open heart surgery. We should know the blood group. We should know the availability of blood. We should know the availability of blood components. Okay, all these three should be reserved adequately. Okay, we do not know when we will land up with a severe bleeding or loss of blood, especially in a pediatric case. Okay, and why you need blood in a pediatric patient for open heart surgery?
the child will be taken into bypass, sir. It will be used as a priming.
The priming itself is done with the blood.
Right.
Why priming has to be done with blood in a pediatric case, unlike an adult where you can do it with a crystalloid?
So that will lead to hemodilution.
Yeah, adult also we are causing hemodilution only.
But it will be much more significant.
Blood volume of the child is very small. If you dilute it further with crystalloid, if there will be hemoglobin will drop to 4 grams and 3 grams. Okay, that is why you cannot afford to use a crystalloid or a colloid prime in a pediatric patient. It should always be blood prime. Okay, so that is for that at least you need the same group blood first. Okay, apart from the emergency need for any heavy bleeding. For priming itself, you require blood. Okay, so that what preparation you should not forget. Right. Okay. Luckily blood is available. It has been arranged and delivered in the theater. Now go ahead with your pre-operative instructions.
Pre-operative instructions, sir. The child can take clear fluids up to 2 hours prior to the procedure, sir. And the NPU status will be explained adequately to the
So you
parent.
can always answer this as I will give the fasting guidelines. 6 hours for solid food, 4 hours for mother's milk, 2 hours for clear fluids. That is like a sloka, you can repeat it in examination. Okay, right. Go ahead. Or in Quran, you can say that and say complete it. Right. If you, right.
Okay. Then I will advise pre-medication with oral syrups, midazolam if available, and at 0.5 mg per kg. And
if supposing you don't advocate any sedative and the child is crying because of anxiety, fear, separation or hunger, right, then what can happen? Is it beneficial or not beneficial?
Not beneficial, sir.
Not beneficial.
Crying, sir.
The crying. Supposing pre-operatively you have advocated starvation. Mother, instead of 6 hours, she does not give anything from the previous night itself. And unusually the child is very hungry and it is seeing the new atmosphere of theater waiting room and all that, and it gets frightened, and all these things make the child cry vehemently. So is it good or is it bad? The child cries.
It's bad.
Why it is bad? I say it is good in a way.
It can anxiety, sympathetic overactivity, like that.
Very good. So it will cause a tachycardia. It will cause an increase in the systemic vascular resistance.
Flow can
So it can flow can get reversed.
sinuses.
On the contrary, what will happen to the pulmonary circulation if the child is crying?
It will be right.
It will be raised. So what will happen? Will it prevent the excess flow from the left side?
Yes, sir.
So it may compensate to some extent. So if the patient is already having a raised pH, then it will be beneficial. It will prevent the excess flow coming from the left side. But at the same time, it can cause increased right side flow, which may also be deleterious. So both things are not good. So we'll see that how it works later in my slide that I'll show you. Right. Okay. So anyway, we want a quiet child to come in. So we can give midazolam. How are you going to prevent the separation anxiety? In spite of midazolam, the child is sleepy, but when you want to take it away from the mother, it wakes up. So how do you avoid that separation anxiety in this case? Because this is a 3-year-old child.
Yes, sir, definitely. Ketamine intramuscular.
Ketamine intramuscular.
At the dose.
What is the dose?
1 to 2 m.
1 to 2
milligram per kg.
That's an, is it intramuscular 1 to 2? What is any name for the dose? Subanesthetic or stunning dose.
Stunning.
Okay. It is also stunning dose. So, but even that 1 to 2 milligram IM, can it cause tachycardia and increase in the pressure?
Subanesthetic stunning dose.
Can you give that subanesthetic dose without an antisyllagogue?
No, sir. We have to give a atropine.
So if you give atropine and ketamine, what will happen?
Tachycardia. And,
tachycardia will happen. Okay, so that is not advisable. So any other method? Would you like to secure an IV line with the mother in the
sir,
child
with
in the mother's
EMLA
lap? So you can put EMLA cream. Always remember in pediatric, always remember EMLA cream. Don't ever forget that. Okay, it's a very useful drug. So you can put that, sedate the child with midazolam, and if you are skillful enough, you can start the IV line in the mother's lap itself, and then give whatever drug you want through that and quietly take the baby inside. Okay. Right. So, okay, all these things have been done. Child has been brought to the OT. How do you attach the monitors for this surgery?
Monitor such as ECG,
Hmm.
saturation probe, if possible.
Where do you apply the ECG electrodes?
Usually in the posterior aspect. Limbs.
Then in the so you want a 5-lead ECG or a 3-lead ECG?
5-lead.
See, you are all masters in cardiac anesthesia. Railway Hospital is famous for cardiac surgery. So you must tell correctly where you put the leads. So you can put it on right shoulder, deltoid, left leg deltoid, then lower limb.
Lower limb for that in the.
You can put it in the right anterior suprailiac area, left anterior suprailiac spine, and the third one on the lower part of the abdomen. Okay. So chest should be kept free. That is the purpose of asking this question. So unlike your regular non-cardiac surgery cases where you put it on the chest, right side, left side, apex and all this area, they should all be kept free and your electrode application must be away from the operative field. Okay, right. Then, so ECG has been applied and securely fixed with micropore tapes and all those things so that they don't come off during the halfway through the surgery, right? Then, the position of the limb, how will you keep the limbs, upper limb, adducted or abducted?
Adducted, sir.
Which limb will be adducted, which limb will be abducted? Both the limbs will be adducted? Okay. Cardiac OT, how are you doing cases? Are you keeping the hands by the side or you are keeping it abducted?
We keep it adducted, sir, by both.
Adducted, okay. And so what precautions you have to take? Where do you keep your IV line? Where do you usually prefer to have the IV line for cardiac surgery?
So
the dorsum of the hand like your normal non-cardiac cases or somewhere else?
Usually we will keep in the inner cubital area.
Cubital, you always prefer the cubital area, isn't it?
Yes, sir.
So
With
you take the basilic vein in the cubital area and extension line will always be there. 50 centimeters or 100 centimeters line will be always there to reach you. Okay. So that you don't want the hand to be abducted and surgeon crowding there and stretching and pushing and all that. So they always keep the hands adducted and have a good IV line in the cubital fossa and then connect it to an extension line with your 3-way coming close to your
IV access.
Fluid behind the screen where the surgeon will be operating. Okay, right. Okay, so you have started the position the patient, applied the monitor. You can put your pulse oximeter, everything on the same hand.
Probe, everything.
Probe also, and you want a temperature probe?
Yes, sir. Definitely.
It's
yes,
definitely you require a temperature probe, right? So, what is the preferred method of induction of anesthesia?
Sir, preferred method is child. We can try inhalational induction.
Okay.
But
what are the advantages and disadvantages of inhalation induction? What agents would you like to use? How do you deliver that? With what carrier agent you will deliver the volatile anesthetic agent?
Advantages are it will be smooth induction, sir.
Will it be a faster induction or a slower induction?
Faster induction.
Why faster induction? The blood flow more or less in the pulmonary circulation?
It's more, sir. So it will be
more.
faster.
So faster. So oligemic lung, it will be less slow. Plethoric lung, it will be faster. Okay, so because of increased blood flow, you can always expect the induction to be faster in a baby with a shunt, intracardiac shunt, especially left to right shunt, number one. But what is the danger of doing this induction? If the child is in a compromised state, let us say the left ventricular function is not all that good.
Myocardial depression.
Depression can happen. Okay, so you can precipitate a failure on that. Okay, so you have to be a little watchful, or you must make an assessment of the left ventricular function and then decide whether you are going to go for inhalation induction or preferably with some other IV induction agent. Okay, right. Okay, right. So the next question I asked is, how are you going to deliver in case you say the inhalation induction can be safe and you decide on that? How are you going to deliver the required inhalation agent?
With the
What is the
O2,
normal way you deliver an inhalation agent for a pediatric induction?
with oxygen and nitrous. And,
Nitrous oxide. Then
the high 6%. If it is mostly
what are the techniques of inhalation induction administration?
high in dose inductions.
Huh?
High dose inhalation agent induction.
What is the exact terminology you
flow.
should use? It should call step up or step down. Okay, it is called step up or step down. So you start from a higher percentage, gradually reduce it. That is called step down method of inhalation induction. But if you start with a lower percentage and gradually increase every 5 breaths or 10 breaths like that, then it is called step up inhalation. Okay, so you have to go for that and induce. And here, can you use nitrous oxide in this case?
No, sir.
No, we have to avoid nitrous oxide and deliver the volatile anesthetic agent in 100% oxygen. Okay? So what is the disadvantage of not using nitrous oxide? What is the advantage of using nitrous oxide?
Disadvantage, more amount of inhalation agent will be required.
More time, it may take a little more time. Why? Why nitrous oxide will hasten the onset of induction? If without nitrous oxide, why it is going to take time? What is it called?
Second gas effect.
Second gas effect. Excellent. So you have to remember that, right? But here, because of the pulmonary hypertension that can be there, you are not supposed to use nitrous oxide, which can get aggravated. Okay. So these are all the explanations that you have to give. Right. So you go ahead with your inhalation induction with 100% oxygen and sevoflurane. Either step up or step down, whatever way you want. How do you know that the child is now gone to the surgical plane of anesthesia when you prefer to do inhalation induction?
From the breathing, rapid breathing will become shallow and slow, deep.
Very good.
And the reflexes.
What reflex? Patellar reflex. Pupillary reflex will be still there. Pupillary reflex, if it is gone, that means position of the eyeball. Position of the eyeball. Roving eyeball will become centrally located and staring. Okay, that is the most important sign of induction, correct induction. Okay, so the respiratory rate will become rapid, fast, shallow breathing will be replaced by slow, deep breathing. Second is, if you have to keep on watching at the eyeball by lifting the upper eyelid. If the eyeball is roving right and left and not still coming to the central position and static, that means still the child is not under. So once the central gaze with a static, no movement eyeball, that means you can be pretty sure that the child has gone to the surgical plane of anesthesia, right? After that, you want to achieve intubation and take over the ventilation. You want to use a relaxant. What is the relaxant of choice? You have examined the airway and found out it can be easily managed, isn't it? But you think it's a grade 1 or grade 2, so you don't anticipate any difficulty. Okay, so can you go for a non-depolarizer straight away? Yes, if that is so, what is the non-depolarizer of choice recommended in the textbooks and in practice by many cardiac anesthetists also? Panchronium. They recommend panchronium. Okay, so pancuronium is their drug of choice. Unlike your atracurium and vecuronium, all these things which are now used, still pancuronium has a role only in this particular surgery. Okay, so
Why?
the preferred.
Can you tell us why? Because we don't use it at all. Pancuronium we have used long ago, but now in regular
prevents
surgeries we don't use it.
tachycardia,
Only cardiac. No?
vagolytic action.
It prevents tachycardia.
I mean vagolytic action.
So
Can maintain heart rate, madam. Prevents tachycardia.
you're right about vagolytic action. So why are you saying it prevents tachycardia?
Vagolytic action. So if bradycardia is one of the deadly problem with the pediatrics.
It maintains heart rate. Pancuronium maintains heart rate. In fact, this is the only place where they use pancuronium nowadays only for cardiac surgery. Either it's even in an adult or a child, pancuronium is used only there. Okay, because it maintains the heart rate because of its vagolytic action.
Nowadays, you don't get it in many of the regular theaters. Okay, unless you specifically ask for that, it has almost become obsolete. Okay, right. So you can intubate with pancuronium. You know the dose of pancuronium because it's now almost become a museum specimen.
Not true.
Same 0.8 to 1.1, 0.08 to 0.1 milligram per kg body weight. Okay, and that can be used for intubation. So after intubation, what monitors to be connected to the endotracheal tube?
Only CT, expired tidal volume.
ETCO2 monitor should be there. Okay. Then you do control ventilation with what?
With airway. You take over the ventilation, sir.
So circle system you can use, or you can use Bain system or pediatric Jackson Rees. Which one you preferred? You are doing a lot of pediatric cases
with
in your case, isn't it?
circle systems.
You have a special circle double tubes, pediatric size tubes, isn't it? So which are attached to the circle system only. So don't get fooled by this sort of questioning in the exam. They will try to confuse you. Okay, so you must be confident in answering that. Whatever you are doing in the theater, you should remember. That's all. Just to tease you and confuse you, only questions are asked like that. Nobody will use a Jackson Rees for a cardiac surgery. Okay, and nobody will prefer to use a Bain circuit also. So it is always the circle system with the soda lime absorber. But the tubings are all specially made for pediatric. Unless the adult tubings, you use the pediatric size tubing. That's the only difference, right? So what are the steps after intubation and checking the proper placement, fixation of the tube, and protection of the eye and all that? What are the steps? Next step? What is the surgeon going to do after painting and draping?
Sir,
You have to do
invasive monitors. Yeah, right. So you have to go for an arterial line
and then
central line. Okay.
Pediatric size and arterial monitor will be connected to a transducer and then will be monitored beat to beat, as well as central venous access for giving drugs as well as to measure central venous pressure.
Very good.
And following which after securing airway and then when connecting the patient to ventilator in pressure control mode, then with this the surgeon will start to drape and then spin. So following all this, sternotomy will be done, sir. And then depending upon.
So any precaution or any additional steps you have to do before sternotomy?
Sternotomy.
Do not ventilate, sir, during that time.
That is when he almost is going to complete the dissection. But before that, he takes the saw in his hand, McMahon's
pain.
It's a very, very painful procedure, isn't it? So you have to judge the adequacy of analgesia. and then try to see if the patient, how do you know the analgesia is adequate or inadequate when he starts the sternotomy?
Sympathetic stimulation will cause tachycardia and
If there is no increase in the pulse rate, that means your analgesia is good enough. If there is a tachycardia occurring as soon as he starts the skin incision itself before sternotomy, that means your analgesia is inadequate. You have to supplement more and then make sure that the heart rate comes down. Okay, then only a patient will be comfortable without pain. Right. So sternotomy, during that time you have to discontinue ventilation. Why?
because the pleura can come.
Pleural can be injured. Very good. So the pleural movement has to be avoided. So you have to disconnect that. Okay. After he has cut the sternum open and puts the retractor, can you start again ventilating?
After putting retractors. Yes, sir.
Yes, you have to ventilate. See, that's all the steps
to
which you
ventilate.
are
You have to
normally
ventilate.
doing only being asked. Okay. So don't, because it is a routine thing, you have to recollect what you are doing every day in the theater. That is the training that you are going to take. Okay. Right. Okay. So when will you stop ventilating?
When the patient have been
Put
completely completely goes
bypass. When he puts completely it's going on the bypass machine, then only we can stop ventilation. So what are the steps in putting the patient into bypass or connecting the patient to cardiopulmonary extracorporeal circulation?
before that they will prime the whole tubing, sir. All the
That is the perfusionist work. He would have done all this work. But what are all the steps you have to follow and the surgeon has to do? The sternotomy has been done, retractors have been placed. What is the first thing they will do? What is covering the heart?
pericardium, sir.
Pericardium. So they will take a pericardial suture and open the pericardium and expose the heart. Okay. Next step.
Venous
What is the
Sir,
approach?
the heparin, sir.
And
The
that's what
anticardial
I'm asking him all the question only to bring out that whether he is remembering heparin and ACT.
Yes, sir.
Okay.
I
Heparin
think
for
you have finished your cardiac posting long back. You are now working mostly in the general theatre, isn't it? So you have forgotten your days in cardiac OT. I did it in 1982 in railway hospital only, my cardiac training. I still remember all the steps. So you have to think of heparin first before they put the cannula into the SVC, IVC or aorta. This the cannulation, the arterial cannulation, venal cannulation is the first step before putting the patient on extracorporeal circuit. So before that, we have to first administer heparin and make sure that the heparin has started working by checking the activated clotting time. What is the normal value of activated clotting time and how much increase it should have after giving heparin?
150 to 180 will be the normal time, sir. Seconds, whereas after giving heparin within 3 to 4 minutes, it should reach at least 300 seconds. And for
Three times it, it should increase at least 3 times, 400 to 460 it should be, okay?
When the
So you
patient is
wait until, so what is the dose of heparin you administer?
4 mg per kg or 400.
How many units? 100 units, 100 to 300 units per kg body weight. Okay, so 100 to 300 units per kg body weight you have to give. And being a small child, you have to calculate carefully and administer. Okay, and then wait for the activated clotting time to increase so that any blood clot does not happen. Then the surgeon will make a purse string suture in the superior vena cava or right atrium. What is the normal approach for correction of the VST? What are all the approaches they can go by, the surgeons?
Transatrial.
Transatrial approach or?
Transventricular.
Transventricular. So most preferably, so they prefer to go transatrial because it is a much smaller, a thinner segment and not much of damage can be, but you have to be careful. Why? Right atrial or left atrial, which they will prefer?
Right atrium.
So what are the complications that can be produced by this right atrial approach?
Conduction abnormalities.
Very good. So you can damage the sinoatrial node. If the surgeon is not trained well enough or is not aware of the anatomy, he can damage the SA node and produce a conduction problem like heart block or some other
Arrhythmias.
complication can happen. Right. Okay. So how does the blood drain from the venous side into the cardiopulmonary machine? Is it by active drainage or by passive drainage?
Active motor will be like
Drainage from the venous side.
venous
It is
side
by
pressure.
gravity, passive drainage. It doesn't, only pumping back is done by the motor.
Motor.
Okay, that roller pump is mainly for pumping back the blood against gravity into the aortic root. Okay, right. So that is the main thing that. So what precautions have to be taken while draining the blood into the cardiopulmonary bypass machine?
Sir, line pressures and air leak.
First of all, you should not have any air bubble. So the surgeon should, that's why they would have seen, they would be tapping the drainage cannula, okay?
Before.
Yeah. It is more than 40 years since I entered a cardiac theatre. I am still remembering what they have been doing right from the small time I worked there. So they have to make sure that there is no, how do you know that all the blood has been drained?
The ventricles will become empty. Heart
What other, heart will? What is the purpose of putting the arterial line?
BP. Yeah, they will,
BP.
and the flow will be.
What flow? What is the pattern of
Pulsatile.
pulsatile flow will become non-pulsatile flow. That is the most important thing. That is the purpose of putting the arterial line also, to watch out whether you are properly draining and whether the circulation is taking place in the absence of heartbeat. Okay, that is the most important. So there have been lot of debates whether you should produce non-pulsatile flow or pulsatile flow to mimic the normal circulation. Okay, there has been a lot of research going on, and finally they said non-pulsatile is also acceptable. Right. So what should be the line pressure? Maximum pressure that you can achieve in the CPP line?
20 or 30 millimeter.
20 or 30?
20 to 30 millimeter.
What is the mean arterial pressure you require for perfusion of organ? If you have 20 or 30 line pressure, will it be reflecting?
Much less. This will be the perfusion. 20 or 30 will be the perfusion.
Renal perfusion.
So it should not exceed 300 mm, 300 millimeters of mercury. Okay, that is the maximum limit, but you should maintain at your normal MAP level. Okay, then only the organ perfusions will be happening properly, right? Okay. And how will you maintain anesthesia once the child or the patient has gone on to the cardiopulmonary bypass?
And usually there will be a side port for giving delivering drugs, sir, through which we have to constantly giving drugs.
Okay. You can't give volatile?
Volatile we can't use.
You can't give. Is it so? You can't give volatile?
Actually, low flow oxygen can be given during that flow.
That is only to keep the alveoli open. But what about anesthesia? Can't you directly infuse or insufflate the blood that is being pumped volatile?
No,
There's a provision for that in the cardiopulmonary machine. You can.
There
is a vaporizer separately attached to that. You can use volatile also to maintain the plane of anesthesia. Okay, go and check your machine tomorrow.
Yes.
Go and sit with your perfusionist, ask him all the details, learn all that before you complete your course. Okay, right. Right. Then, okay, surgery has been, what are the methods of surgical closure of the defect?
Sir, hypotonia, sir.
Yeah, Mostly they go into hypothermia also, but for this surgery, they may not need very deep hypothermia, but all the patients will be becoming almost 20 to 22 degrees centigrade will be their body temperature. Okay. And sometimes cardioplegia also may be required to stop the heart if it is not completely becoming akinetic. Okay. So what are the techniques of correction or repair? It can be with a normal available. If it is a small opening and especially muscular opening, they can mobilize the muscle and close the defect. Okay. Otherwise, they have to go for a patch, which are either a pericardial patch or a synthetic patch. Okay. So depending upon the size, they decide and do the closure. And what are all the complications that can be produced by the closure or the surgical maneuvers?
As mentioned earlier, conduction abnormalities can be there.
Very good. Septum is very important for the traversing of the bundle, his bundles and then the branchings. Okay, so that may be interrupted. So you have to, we can't see them by naked eye. So they have to be very careful while doing that. And then
residual.
Sometimes the closure may not be complete. There may be a small hole, residual lesion may be there. Okay, so these are the things that can happen. Right. After the surgeon says he has completed the defect repair, how do you bring out the child?
Sir, first half of the blood will be pumped back into the body to look for return of spontaneous.
What is the process called?
Rewarming. First.
Rewarming is just making the
blood
patient
has to be warmed before. Then weaning from CVP.
Weaning from cardiopulmonary bypass. Just like weaning from your ventilator, you have to wean the patient from the cardiopulmonary bypass. That is the name for that. So what are the things that you have to take care when you wean a patient from cardiopulmonary bypass? What is the mnemonic you have to remember? You put in a central line, what do you call that? What catheter you call it as? When you put in a IJV catheter, don't you call it as a CVP catheter?
Yes, sir.
Same mnemonic is there for weaning from bypass. What are all the points that you have to remember? Described by somebody whose name you can easily remember if you are a person who enjoy your liquor. You are not, you are a very staunch teetotaler. Then you won't remember. The Romanov and Royster CVP mnemonic. Have you heard of that?
Yes, sir.
Romanov, ROMONOFF, and Royster CVP mnemonic. What does the C stand for? What are the things?
Color.
Cholera. Cold, conduction, cells, calcium. Okay. Then V for visualization, vaporizer, ventilator, volume. Then P for the pressure, pressor, potassium, protamine. Okay. Like that, for each one there is things which are all to be, if you take care of all these things, you will be able to successfully wean the patient from the cardiopulmonary bypass. Okay. And you can identify what is lacking also by remembering this mnemonic. Okay. So read that well before exam. They may ask you, especially if they know that you are coming from a center where cardiac surgery is done, you have to know all these things. Right. So after that, you have reinfused the blood back into the heart and successfully weaned the patient from cardiopulmonary bypass. Okay. Can you just complete the after the sternal closure and application of all the dressing, everything? Can you extubate the child on the table?
Not every case is possible, sir.
So what do you normally do?
we electively ventilate for at least 2 to 3 days, and then
2 to 3 days for a VSD.
no sir, 124 hours. But,
Supposing you do it for 2 to 3 days, what is the reason? Why should you do it for such long period? Which are the indications for prolonged ventilatory support?
persistent high pulmonary vascular pressure.
Very good. If the preoperative pulmonary pressures are quite high and they are not reversible, then you may have to keep them on ventilatory support for quite a long time. On the contrary, if the preoperative pressures are
Such patients will require a particular drug, no, sir, when they come for when the patient is on ventilator.
Bosanton, sildenafil, nitric oxide, all these things you
know.
can just, you can try, and then if whether they are responding, then if they respond well, they will be able to come off the ventilator much easily. Okay. So that is the whole method of managing pre-op, intra-op and post-op. Okay. And frequent arterial blood gases also have to be done. So the purpose of arterial line is one, to find out the pulsatile and non-pulsatile flow, and also to do frequent blood gas analysis to find out the ventilatory and metabolic state of the patient. And intraoperative urine output monitoring is very, very important. And temperature monitoring and rewarming and bringing the patient to normal body temperature before reversing is very important. Because you may be taking the patient to ventilator straight away, you may not be reversing many of the times. You will be taking the patient with the residual paralysis still there, so that that will help in tolerating the ventilation also. Okay. And post-operative analgesia, how do you manage? What are all the newer modes of providing analgesia? Nowadays we talk about multimodal analgesia for every surgical procedure. Is there any multimodal for cardiac surgery, post-cardiac surgery?
Ketamine sub-anesthetic dose.
Ketamine infusions, not sub-anesthetic dose, but infusion is being provided. Okay. Then any regional technique? Any
Erector spinal blocks.
Rector spinal block, chest wall blocks can be done. Okay. Right. So, supposing a child or a adult grows with VSD without much of a symptoms, and they come for an incidental surgery, how do you manage those patients?
Here also,
non-cardiac surgery in a patient with a congenital heart disease. What are the 4 principles described in Miller? They have given that as principle 1, principle 2, principle 3 and 4. Did you read about it? I think Miller is a taboo. Nobody reads, and none of the postgraduates read Miller. Isn't it? There are 4 things.
Hypotension and hypoxia has to be avoided.
Hypotension, hypoxia, that is all very common, normal. But for regular congenital heart disease patients coming for non-cardiac surgery, they talk about 4 things. One is the presence of cyanosis, pulmonary hypertension, left ventricular failure and congestive heart failure. I mean left ventricular dysfunction and congestive heart failure. So all these, the intracardiac shunts and the pulmonary hypertension, congestive failure and cyanosis, all these things are the things which you have to roll out. Right. Any need for endocarditis prophylaxis in this surgery?
If it is not repaired, no need, sir. But if it is repaired with a prosthetic or something, prosthetic material,
or if there is any residual lesion, then they have to be given endocarditis prophylaxis. Okay. Okay. What about paradoxical air embolism? Sir, is it common in VSD or is it common in the other congenital ASD?
It's common in other congenital.
ASD. When will paradoxical air embolism happen in VSD patients?
VSD when the flow reversal occurs.
Very good. The flow is reversed, then only it can happen. Whereas in ASD, what is the mechanism? Because ASD, the atrial pressures are much less compared to ventricular pressures, isn't it? But there also, there is commonly left to right shunt only is happening. But how can
But
the
minimal,
air which is
there is also a persistent minimal amount of right to left shunt in ASD.
What is the mechanism? Exactly. Very good. How does it happen? Minimal right to left shunt, how does it take place in ASD?
Exactly.
Exactly. So there are two mechanisms. One is squeezing mechanism, another is the negative pressure mechanism. Okay. So when the left atrium, when it is starting to drain during the left ventricular diastasis, first is the rapid filling phase, no? So when the pressure starts dropping, there is a negative pressure created. So during that time, the right ventricular flow will happen through the patent ASD, atrial defect. Second thing is when the right atrial pressure increases during atrial contraction, initially there is a pressure which is likely to push if there is any air bubble to the left side. Okay, so these are the two mechanisms that are described for the minimal right to left shunt, which is the cause for the air to enter from the right side directly into the left side and cause the so-called paradoxical air embolism. So this air, where all can it go and get lodged? Why we are more worried about this paradoxical embolism, and you are repeatedly told to be very meticulous in seeing that no air bubble is there in the IV line. So which are all the organs which can be affected?
Brain, kidney.
Brain, coronary, kidney, and the extremities. Okay, so these are the four sites: brain, coronary, kidney, and extremities. All these locations it can get enlarged and you can have a occlusion. Okay, very important for that. Vasanthi, anything to be added?
Sir, fast tracking, sir.
Fast tracking, excellent.
Fast tracking.
Yeah. What about fast tracking? Nowadays we talk about fast tracking in all sorts of cardiac surgery.
Sir, asymptomatic mild case, moderate cases can be taken as a fast track case.
And extubated much more earlier than
on table or 4 hours.
On table or within 4 hours. Okay, depending upon the protocol or the
there is no recent infection of LRI or such things.
Very good. Great. So can I share my screen for a minute? You have facility for that?
Yes.
Yeah, I think we can. I'll just show PowerPoint. Are you all able to see?
Yes, sir.
No, sir.
Huh?
Yes, sir.
Therida, Therilla?
There is.
Yes, sir.
You can see that, no? So I
Yes,
just go ahead with a few points that can be added as a summarizing conclusion. So a ventricular septal defect is an abnormal communication between the two ventricles, and it's the most common form of congenital heart disease. 75% of the congenital heart disease is mainly VSD only. VSDs may be associated with other congenital abnormalities such as trisomy 13, 18, and 21, as well as the anomalies like vectoral and charge syndrome. The charge syndrome is coloboma of the eyelid, heart defects, choanal atresia, retardation, genitourinary problems, and ear anomalies. That is the acronym for this second condition. Vectoral we all commonly come across. So remember this charge syndrome also. So what are all the locations where the VSD or the communication can exist? There are 4 classifications. One is the membranous, which is the most common. Then it can be at the inlet, or it can be outlet or subarterial, and muscular and membranous. These are the 2 common areas of defect. And sometimes it can be in inlet and outlet. 5 to 7% is at the outlet, 5 to 20% is muscular, and 5 to 10% is the inlet. So this is the distribution. And if there are multiple defects in the same patient, it is called the Swiss cheese type of multimuscular defect, especially in the muscular portion, involving all components of the ventricular septum. Is extremely difficult to close surgically. So that is a challenge to the surgeon. Then pathophysiological consequences of VSD are influenced mainly by its size. The major determinants of the hemodynamic state of the patient's VSD are, first of all, VSD size. What is the systemic vascular resistance? What is the pulmonary vascular resistance? And what are the associated intracardiac anomalies itself, like aortic insufficiency or obstruction to LV, RV outflow, or valvular defects? If there are associated, they also have a bearing on the VSD problem. So VSD size, SVR, PVR, associated anomalies. All these four things determine the hemodynamic functionality of the patient. And by going for the classification of the size based on the maximum diameter of VSD, which is compared to the normal aortic valve annulus. So it is not by the size alone, it has to be compared with the aortic valve annulus, and small, which means less than 1/3 of the normal aortic valve annulus size. If it is 1/3 to 2/3 of the aortic valve annulus, it is called moderate, and more than 2/3, it is called large. So that is the small, medium, large, like your dress size. It is based on the comparison with the aortic valve annulus. Then based on the pulmonary blood flow, QS to QP ratio. QS is the systemic flow, QP is the pulmonary flow. So based on that, again, we can classify them into small, moderate, and large, where the pulmonary blood flow to QS ratio is 1.5, moderate 1.5 to 2, large is more than 2. So there will be more than 2 times the flow which is happening. That again will produce a lot of load. And spontaneous closure of VSD occurs in up to 80% of muscular defects, especially if they are small. So that is why even if you hear a very harsh small murmur, especially in children with cleft lip and cleft palate, we used to get them for lip repair at the age of 2 months, 3 months. If I hear a very harsh like this, a hollow systolic murmur, I won't be bothered about that child at all. And by the time it comes for palate repair or future nose correction or some repair, I have seen many of them completely outgrown that, and the VSD would have automatically closed. Whereas if it is a soft murmur indicating it's a large flow, large opening, they do continue to have that even when they grow. They may go for a cardiac correction at the age of 3 or 4, as you have presented now. So a very harsh, very short murmur is always, prolonged murmur is always indicative of a small hole. A soft, shorter murmur is always indicative of a larger hole, which can make it even clinically by auscultation. And then children with large defects, if left untreated, will gradually develop pulmonary hypertension and pulmonary vascular obstructive disease. This will eventually result in what is called the Eisenmenger syndrome, where the reversal of the shunt will happen and patient will become cyanosed. The pulmonary artery pressures higher than systemic values, which are suprasystemic PA pressures, and reversal of the shunt across VSD from left to right to right left, and cyanosis will happen. And the diagnosis of a normal VSD can be diagnosed antenatally by ultrasound examination. Nowadays we do for anomaly scan. That time itself we can find out, because the development takes place at the 28th week itself. And a small VSD will have a pansystolic low intensity or a high pitched murmur on the upper left sternal border. Precordial thrill may be palpable. Normal growth and development will be there. Child remains totally asymptomatic. So this is the clinical features of a small VSD. Whereas moderate VSD, you will hear a harsh pansystolic murmur on mid-sternal border radiating to the precordial area. Soft thrill and prominent RV pulse, which possibly also with a L-ventric impulse will be there. growth and development may be affected. Signs and symptoms of congestive failure also may be there. If it is a very large VSD, physical findings are identical to moderate sized defects. Prominent trill apical impulses, hyperactive pericardium, increased intensity of S2. This second sound is increased louder because of the increased pulmonary flow. RV dilatation and hypertrophy seen in and the rise in PVR are more marked in large VSDs. If increased PVR and right to left shunt occur, murmur may become decrescendo, minimal or absent. So, a large VSD in the late stages may completely, the murmur may disappear also. Signs and symptoms of marked congestive heart failure, poor growth and development, tachypnea, dyspnea, respiratory distress, recurrent pulmonary infections, all these things can happen. Now, what are the special investigations you can do is oxygen saturation. Usually normal, can be low with intercurrent respiratory tract infection or pulmonary edema, in which case it improves with oxygen therapy, whereas Eisenmenger syndrome will not improve because it's a central shunt occurring from right to left. Not significant improvement will happen in oxygen saturation with the oxygen administration. And chest X-ray in normal small defects, cardiomegaly and increased pulmonary markings will be there in moderate. So small defects, you will see an absolutely normal chest X-ray. Moderate to large, you will find a cardiomegaly and pulmonary edema-like features. And ECG is normal in small VSD, shows LA dilatation and LV hypertrophy in moderate VSDs and evidence of biventricular hypertrophy in large VSDs, as I told you earlier. In hematology, you will have a typically normal except for patients in Eisenmenger syndrome who may develop polycythemia, thrombocytopenia and coagulopathy as complications of sinuses. But in case like what you have presented, if the nutrition is poor, there may be anemia also. And in echocardiography, it is usually only imaging modality required to determine the diagnosis, size, location, and also provide information about chamber size, wall thickness, estimates of right ventricular and pulmonary pressures, as well as associated anomalies. So echocardiography is a very, very important investigation. And cardiac catheterization, not routinely done, but performed when there are remaining questions about anatomy and pulmonary vascular resistance and its response to therapy. Now, medical management of this condition is patients with moderate or large defects with signs and symptoms of congestive heart failure are frequently prescribed diuretics. That is what happened in your case. And angiotensin conversion enzyme inhibitor also used for remodeling of the heart. For small number of children with severe congestive heart failure and pulmonary edema, pre-op admission to the intensive care and intravenous diuretics and inotropes may be necessary. Electrolyte imbalances should be carefully monitored and treated with special attention in children treated with diuretics or AC inhibitors. Coming to the surgical management, what are the indications for surgery? Congestive heart failure and or failure to thrive, refractory to medical therapy. Moderate or large defects unlikely to close spontaneously with or without symptoms. And development of aortic valve leaflet prolapse or aortic insufficiently along with that, because at the very high level, if there is a defect, it is very close to the aortic wall, which may get affected. And asymptomatic children with a QP-QS ratio of more than 2. If the pulmonary flow becomes more than 2 times the systemic flow, then they are also to be operated, otherwise they will go for pulmonary hypertension, right ventricular failure and all these things. What are the contraindications for surgery? A small proportion of patients with pulmonary hypertension are not suitable candidates. If it has been very severe and not amenable to your, you can do a trial with the pulmonary vasodilator like bosentan or sildenafil or nitric oxide. And if there is no significant reduction in the pulmonary pressures, they do very badly after surgery. And what is the corrective surgery done is consists of a surgical patch closure of VSD requiring open heart surgery and cardiopulmonary bypass and cardioplegic arrest. Most defects can be closed successfully by an incision made in the right atrium, which is called transatrial approach, while some may need close through the right ventricle, pulmonary artery, or infundibulum. So these are the other approaches. There is another technique called pulmonary banding, especially in patients with severe pulmonary hypertension, previously employed as a two-stage to allow growth until definitive surgery could be performed. It is now usually reserved for very critically ill neonates or those with associated anomalies who may be too ill for early corrective repair, and some with multiple VSDs. So if there are multiple VSDs like the Swiss cheese, you go for first is what is called the pulmonary banding, which is nothing but to reduce the flow into the pulmonary circulation, not mechanical constriction, so that not much of blood can flow and damage the pulmonary vasculature. Then transcatheter closure, even though VSDs have been successfully closed by devices inserted through a major blood vessel, especially through the femoral, equipment size is a major limitation to their use in therapy as a therapy in children. So one of the problems. Coming to anesthetic management of CPB for VSD closure. So these are all the steps that are given nicely. Inhalation induction with sevoflurane, which we discussed. Maintenance with isoflurane, including CPB delivered to the CPB circuit. And intraoperative analgesia, fentanyl, you can give up to 30 to 50 mics per kg. Normally, we are scared to give more than even 1 to 2 mics. But in cardiac surgery, there are two methods of cardiac surgery. Either it is called opioid based or volatile based. In opioid based, you go for a very heavy dose so that both intraoperative pain is taken care of and post-operative ventilation and analgesia are also managed with that same dose. Then muscle relaxation with pancuronium, invasive monitoring including central venous and arterial access as well as monitoring line. In some centers use transesophageal echocardiography to assess the repair at the on the table itself, and anticoagulation with 400 units per kg of heparin. Availability of previously cross-matched blood products, red cells, platelets, etc. Prophylactic antifibrinolytics drugs are given. Mild hypothermia, usually CPB 34, but some centers use less than this also. Hematocrit higher than 21% during CPB and 30% immediately before separation. So during CPB there may be some dilution which is accepted, but it should be at least 30% before you wean from the bypass. And modified ultrafiltration, sometimes used to remove free water and prevent overloading, so that the strain on the kidneys also is less if you use this before separation from cardiopulmonary bypass. And children with severe congestive heart failure or pulmonary hypertension will have present with the high pulmonary vascular resistance. In these cases, important to avoid excessive myocardial depression from anesthetic agent. A carefully balanced technique with a support myocardial contractility with the inotropes, which can be in the form of milrinone and 75 microgram per kg over 30 minutes, followed by continuous infusion at the rate of 0.25 to 0.75. And nitric oxide also can be considered before separation from CPB to reduce PVR. Now coming to fast track procedure, asymptomatic children with predictable uncomplicated VSD closures can be considered for fast track procedure, aiming for early tracheal extubation either in the OT or 4 hours after admission to ICU. Use of moderate doses of fentanyl 10 to 30 microgram during case, bolus doses of atracurium. So here if you plan for fast track, they recommend atracurium, intravenous paracetamol, local anesthetic wound infiltration, antiemetic administration in the OT to facilitate extubation in the fast track procedure. And in the immediate post-operative period, separation from CPB is usually smooth and uneventful, but it is important that immediate post-operative period to monitor and correct possible electrolyte imbalances, maintain normothermia, control possible surgical site oozing, Thromboelastography may be useful to guide further if there is any requirement of protamine or administration to treat any anticoagulation abnormalities. Now the complications can be residual VSDs. Treatment is surgical or transcatheter closure also sometimes results in residual lesion. Size and clinical significance may not be worth the risk of returning to cardiopulmonary bypass or later re-intervention. Sometimes very small residual lesions, you can ignore them. Heart block is another major problem treated by atrioventricular synchronized pacing with the epicardial pacing wires. Arrhythmias can happen. These include junctional ectopic tachycardia, which can occur in children or those involved with the VSD repair, most often Fowler's tetralogy. JAT should be treated aggressively by minimizing catechol levels, cooling the patient, sedation, muscle relaxation, and amiodarone. Anesthetic management of non-cardiac surgery in patients with VSDs. Safe conduct of anesthesia for non-cardiac surgery can depend on multiple factors, individual patient's clinical condition and nature of the surgical procedure and local resources available. All these things to be taken care. And children with moderate to large VSDs with a high pulmonary flow to systemic flow and the evidence of congestive heart failure, particularly patients with long-standing uncorrected defects with pulmonary hypertension, they belong to the high-risk group. So you have to be, they should not take it lightly and operate in a center where without much facilities are there. And patients with successful correction of VSD can be thought of as being compensated and treated patients without cardiac disease. So if the closure has been done correctly and there is no communication at all, they can be treated as normal patients. Now, endocarditis prophylaxis is indicated for patients with uncorrected or residual lesions for the first 6 months after correction with prosthetic material. It is not recommended for patients with fully repaired VSD. So if the repair has been done with a natural patch graft or pericardial patch, or you are mobilizing the tissues and closure, those patients do not require an endocarditis prophylaxis for any future procedures. Now the shunt flow dynamics, this is what I said about how the communication happens between the right atrium and the left atrium in ASDs. See, the atrial contraction, normal contractions are going like this. There's right to left shunt happens, which is called the double bump. During, see, this is the pressure which is 0 going up to 12, coming down and then coming down here. Then it goes to the negative side slightly before the next thing happens. And this is the late ventricular systole. So atrial contraction, there is a negative pressure, left ventricular systole, then the start of diastole, atrial contraction again. So during this period, there is a small negative pressure and an increase in right atrial pressure, both of them resulting in what is called the double bump effect in the right atrium, which only is responsible for shunting of blood from the right side to the left side. That's called the shunt dynamics. The direction of any shunt requires two things, but either a pushing force or a pulling force can generate this gradient. A gradient can be established by squeezing on the given chamber X into chamber Y. The chamber Y acts as a vacuum. The direction of the gradient towards Y can be generated. So both the mechanisms will help. Now if you see this picture, when there is an increase in the PVR compared to the SVR, there is a right to left shunt, which results in hypoxia. On the contrary, if there is an increase in SVR compared to PVR, what should happen? It should be a left to right shunt resulting in pulmonary congestion. So the ideal things will be to have a normal PVR, neither a high PVR or a low PVR, but a normal PVR, but a slightly reduced SVR. If you have that, then it will be ideal for the correct flow through the systemic circulation as well as the pulmonary circulation. So our aim when we deal with patients with an intracardiac shunt should always be a normal PVR, a slightly low SVR, which should be ideal. If you see the older textbooks, they always said you maintain a very high SVR, but this high SVR will result in pulmonary congestion. So the latest the concept that is being advocated is a normal PVR with a slightly low SVR, which is considered ideal for maintaining a normal QP-QS ratio. That is the idea of doing this. Okay. And so I come to summarize anesthetic management of ASD also I have taken up from that thing. Avoid cyanotic shunt, that is right to left, by preventing profound decrease in SVR or acute increase in PVR. Avoid increasing the magnitude of left to right shunt by increasing the SVR and causing more congestion. Maintain SVR and PVR is ideal. Minor decrease in SVR are preferable to increase in SVR. So avoiding air bubbles to circulation. Minimize use of nitrous oxide or avoid nitrous oxide totally. Avoid ketamine in most circumstances. So that is the recommendation that is given. And atrial septal defect summary is major direction of shunting is left to right. Minor right to left shunt also can be observed. So shunt directions do not remain static, which is dependent on volume overload, especially leading to right ventricular dilatation, increasing pulmonary vascular pressures, and Eisenmenger syndrome. In ventricular septal defect, major direction of shunting is again left to right. Minor right to left shunting can also be observed. Faster developing and more pronounced effects on pulmonary vasculature compared to ASD because of the high flow and the high pressures. Shunt reversal and Eisenmenger syndrome can occur by second year of age in very large ASDs. So I think these are all the things that I would like to share. Stop. So anything more to add, Vasanthi?
So everything is covered, sir.
Covered.
Beautiful covered.
Purnima, anything to be added, ma?
No, sir. Thank you, sir. It was wonderful.
Right, Sangeeta. Anybody has got anything to add or correct or comment? You are welcome. Okay.
Sir, thank you, sir. Thank you, madam.
Thank you
It
very
was
much.
wonderful
Right.
session.
Thank
And actually, these cases after
Pardon?
surgery coming up for adulthood and coming up.
Yeah. Okay. Thank you. Good night.
Your voice is breaking. All right. Okay. Thank you.
Yeah. Thank you very much. Thank you, Vasanthi. Thank you very much.
Thank you,
Hello,
sir.
sir. Hello.
Thank you.
Thank you.
Thank you, sir. Thank you, madam.
Thank you, sir.